hematologic malignancy mainly, I will talk about lymphoma and leukemia. We should talk about the manifestation. Any imaging of these diseases should include the manifestation of primary disease and the manifestation of therapeutic methods, اللي هي الكيموثيرابي and the effect of radiotherapy. دكتورة عايدة إن شاء الله هتتكلم على the effect of chemotherapy in the next lecture, so I will focus on radiotherapy. And in addition, the effect of immunosuppressive state that can be caused by the disease itself or the chemotherapeutic agents. Primary disease في hematologic malignancies له different manifestation. على رأسها الهيموريج اللي كان بيجي بسبب الليكوسايتوزيس اللي بتحصل والابنورمال بلاد بروفايلز اللي بتحصل مع العيانين دولت. Meningeal infiltration, parenchymal infiltration, bone infiltration, and orbital and spinal infiltration. Hemorrhage is most commonly seen in acute leukemias and usually or may lead to death in many cases. Usually happens when the leukocytic count is very high, more than 300 per cubic millimeter. Like in this case, extensive hemorrhage seen within the ventricles and in the corpus callosum and in the brain parenchyma. In this 8-year-old patient with acute lymphocytic leukemia with leukocytic count over 800,000 per cubic millimeter. Again, the hemorrhage can be presented as as microbleeds that's shown as susceptibility, blooming artifact on susceptibility weighted images, as in this patient. The other parenchymal primary disease manifestation is meningeal infiltration that can be lepto or bachimeningeal, ependymal, or affecting the nerve roots. More common with with leukemia and with secondary lymphoma. The primary CNS lymphoma usually present as parenchymal lesions, not meningeal infiltration. As in this patient, there is bachimeningeal enhancement along the anterior aspect of the left frontal lobe. In this patient with acute with ALL, sometimes it affects the bone with extracalvarial soft tissue component and intracranial extraaxial bachimeningeal infiltration. Large ependymal infiltration, as in this patient, seen as markedly enhancing intraventricular subependymal lesion within the temporal horns with extensive brain edema or in the brain parenchyma. The leukemic infiltrations also showed diffusion restriction on diffusion weighted images. Ependymal infiltration also seen in secondary lymphoma, seen as diffuse ependymal enhancement and thickening, as in this patient with non-Hodgkin lymphoma. In this patient, there is also a parenchymal nodule. Meningeal seedling also can be seen in lymphoma and leukemia, seen as leptomeningeal enhancement or enhancing foci in the spine, as in this patient, nerve root enhancement and focal enhancement in the cervical region. Parenchymal infiltration is most commonly seen with lymphoma, and it's very unlikely to be seen with leukemia, although it can happen. Typical parenchymal lesions in lymphoma will appear as hypo intense on T1 with diffuse enhancement. However, low-grade lymphomas may show no enhancement or mild enhancement. Notch sign is seen in primary CNS lymphoma. Usually on T2 weighted image, the lymphomatous infiltration appears iso to hypo-intense, although some hyper-intense, some lesions showed hyper-intensity, especially in necrosis or immunocompromised patient. The characteristic feature of lymphomatous infiltration is very low ADC, usually below 700. Also, in MR spectroscopy show large choline peak, reversed choline creatine, and markedly decreased NAA. And on perfusion, the lymphoma showed ISO, so slightly hypoperfused, and if it showed hyperperfusion, it will be much less than expected for high-grade glioma and metastasis. Most of lymphomas also showed avid uptake on PET-CT. This is a case of primary CNS lymphoma, which is very rare in children. Showed characteristic intraaxial lesion within the left cerebellar hemisphere with characteristic notch sign, as shown as a dimple on the surface of the lesion. Marked diffusion restriction seen in this patient, which is very characteristic for lymphomatous infiltration. Again, diffusely enhancing lesion with marked diffusion restriction and markedly lowered ADC value, and showed hypoperfusion on relative cerebral blood flow volume. Also, the lymphomatous infiltration showed avid uptake on PET-CT evaluation. Characteristic appearance of lymphomatous infiltration on MR spectroscopy: very high choline peak, markedly decreased NAA, some lactate peaks. Parenchymal infiltration in leukemia is very rare and non-specific, as in this case, showed multiple intraaxial ring-enhancing lesions surrounded by edema, and it has no specific imaging feature. Orbital infiltration can be seen in both lymphoma and leukemia, as in this patient. Maybe unilateral, appears as iso-dense lesion on CT, iso-intense on T1 weighted image that showed diffuse enhancement. Bilateral orbital affection in leukemia. Retinal infiltration can be seen in leukemia, which usually shown as retinal hemorrhage, as in this case. Also, optic nerve infiltration by leukemia can occur and seen as diffusely enlarged optic nerve that showed moderate enhancement. Lymphomatous infiltration in the orbit can take any form, like in this case, diffuse non-ill-defined enhancing mass within the orbit that showed marked diffusion restriction. Marrow infiltration can be seen in both leukemia and lymphoma, and the most important feature of marrow infiltration in the spine that the infiltrated marrow display hypo-intense signal compared to the adjacent disc, and sometimes it appears hyper-intense on T2, sometimes ISO, but the most important feature is being hypo-intense compared to the adjacent disc. The second part of this lecture is the imaging of radiation-induced neurotoxic effect. Radiotherapy neurotoxicity usually divided into either acute injury within 1 month, or early delayed injury within 6 months, or late delayed injury more than 6 months after radiation. The acute and early delayed post-radiation injury are usually transient and with no specific imaging features apart from mild edematous or swollen brain in the acute phase that resolves after adequate management, or subtle hyperintensity in the white matter. The delayed effect that occurs after 6 months, this is the most important, and can be, the delayed effect can be presented as leukoencephalopathy, radiation necrosis, cerebrovascular complication, cranial nerve injury, endocrine complication, or secondary neoplasm. This is a characteristic appearance of post-radiotherapy leukoencephalopathy appears as bilateral T2 and flare hyper-intense signal that usually preserve the U fibers with no enhancement or mass effect and no diffusion restriction. Sometimes cystic change occurs resulting in post-irradiation leukoencephalopathy with cystic degeneration. Another type of leukoencephalopathy is disseminated necrotizing leukoencephalopathy, or DNL, that is acute and severe, potentially fatal complication. Can result from methotrexate therapy alone or more common in combination with radiotherapy. And it appears as diffuse hyperintense signal involving the cortical and subcortical white matter, and the main differential is it showed patchy enhancement and very poor, very bad clinical deterioration. Another case of DNL that showed areas of restricted diffusion as well. Radiation necrosis is far much less likely to occur in children compared to others, but usually it occurs after a latency period more than several months, up to 1 year, and the range can be, it can occur up to more than 10 years after irradiation. Typically demonstrated as enhancing mass lesion with central necrosis and reactive edema, and the enhancement may be ill-defined or areas or soap bubble appearance, like there is a necrotic component surrounded by marginal enhancement, and multiple lesions can occur. It's very uncommon in pediatric age group, like in this case, after irradiation showed multiple small foci of enhancement in the bones. Radiation-induced cavernous malformation, it's exactly shown as cavernomas, shown as T2 hyperintense signal surrounded by hemosideral ring, and showed extensive blooming on SWI. Mineralizing microangiopathy usually occur in children less than 10 years, and in most cases it is asymptomatic, usually shown as a hypointense signal on T2 and gradient images, subtle hyperintense signal usually affecting the basal ganglia or the subcortical white matter, and on CT it appears as dystrophic calcification, like in this case. One of the rare radiation therapy toxicity is the stroke-like migraine attack after radiotherapy, or SMART syndrome. Patients usually present years after radiotherapy with migraine-like headaches, seizures, and subacute stroke-like episodes with symptoms such as hemiplegia and aphasia. Attacks are typically subacute in onset, differentiating it from the stroke, and resolves after 1 week. And the imaging feature is very challenging in this case, and this should be put in mind in following up patient with history of radiation. As you see, it is seen as diffuse swollen gyri affecting the temporo-occipital lobe that showed diffuse gyral enhancement, which is very similar to either encephalitis, sometimes ischemic changes, and the diffusion is usually negative, but sometimes it shows restriction, but much less than expected in ischemic lesions. Another case of SMART syndrome showed diffuse gyral swelling with gyral enhancement with no diffusion restriction. Second neoplasms are relatively rare neoplasms that mainly related to radiation. It is usually developed after combined CNS radiation and chemotherapy. It includes meningiomas, gliomas, nerve sheath tumors, and sarcomas. The latency period between the treatment and development of these tumors is very variable and usually not less than 1 year and up to 15 years after exposure to radiation. This is a case of secondary meningioma following radiation. Another meningioma, parafalcine meningioma following irradiation. High-grade glioma in a 13 years old girl treated for acute lymphocytic leukemia, and another case of high-grade cerebellar glioma following chemotherapy. In this patient, in this 3 years old girl who has been treated for acute ALL, shows right parotid neoplasm that was proved to be low-grade carcinoma following irradiation. The effect of chemotherapy will be discussed, inshallah, by Dr. Aida in the next section. Effect of immunosuppressive states that can result from the disease itself or the chemotherapeutic agent. Many infections can occur in this immunosuppressive state, like fungal abscesses, like in this case, that showed ring-enhancing lesion with central diffusion restriction. And this is a case of invasive cerebral aspergillosis. And in this case, due to the distribution of fungal infection affect lungs, paranasal sinuses, muscles, livers, these patients are candidate for whole body diffusion MRI. Candida infection in a 10 years old girl with acute lymphocytic leukemia appears as tiny hyperintense foci on flare that showed marked restriction on diffusion weighted image. Fungal meningitis again, seen as leptomeningeal enhancement along the anterior aspect of the medulla and along the visualized spinal cord. Other opportunistic infection, other rare type of viral infection is cytomegalovirus infection in immunocompromised child, seen as subtle ependymal enhancement, diffuse ependymal enhancement. In this patient, there is hyperintense signal in the left optic nerve that showed restricted diffusion in diffusion weighted image, and this was a varicella zoster optic neuritis after in a patient with leukemia. So the wide range of CNS abnormalities that occurs in hematologic malignancies is related to either the primary disease or the management or treatment method, and the radiologist should be aware about the manifestation of the primary disease and the complication of therapy, knowledge of the treatment plan, and the amount of time elapsed since radiotherapy is essential for proper diagnosis at follow-up imaging. Thank you.